Thank you very much. Faculty, thank you very much for the invitation and the chance to present some of our thoughts about renaissance of ESWL in the future. So my picture might look a little different for 2015, and I hope I'm right, than Professor De La Rosette's picture. But maybe we have time to discuss these matters with all the experts which are available here. Now, just want to go back in the earlier times where we had results which were remarkable. I mean, stone-free rate of 90% in our first series with ESWL. That was significant improvement. And in the following time, we look more and more to get back to these results. The other thing is what was important at that time, we did the functional study of the kidneys, which we had treated, and found the kidney function unchanged after ESWL exposure. So that might have been one reason why these techniques become very familiar. And as you see here, and that's just a kind of a preliminary picture, which different type of ESWL machine has been produced by different companies. They mainly differed in the way how they selected the energy source from hydraulic, electromagnetic, and piezoelectric energy sources. So, but time goes on and things changed by different reasons. And what I think when you look for the numbers of ESWL, they are still the majority, as you see in that graph, but endoscopy gained percentage of stone treatments, and open surgery nearly dropped to nearly zero. What might be the reasons? That might be that the new lithotripter generation were less efficiency than the HM3, and on the other side there was a rapid progress in endoscopic technology like flexible URS, holmium laser, and most of these things which Professor De La Rosette has mentioned. Now, this trend seems to go back a little, and if you see here, which was just published from the Oxford group in the British Journal of Urology, there is again an increase in ESWL performed. So this drop, which you have seen in the pictures 4 or 5 years ago, has regained, and you see it on more than one centers. And the other thing is, if you look for the listed publication about ESWL, and I think it's very important when you go and look what has been published and what has worked scientifically. ESWL, after a significant drop, has gained, and when you look for the actual data, and that was what we were missing in Mannheim when we discussed about that, there are significant numbers of scientific publications meanwhile about ESWL. So it seems to be much more interest. But nevertheless, everybody asked, what can we improve in regard to our ESWL machines or in our strategy to perform ESWL. And I mean, there are certain points, the shockwave systems, the stone localization, patient positioning and coupling, where you can improve in regard to the technology. And I just want to come to some of these points. And in regard to the application itself, you can change indication, treatment strategy, supportive therapy, and a very important point where we have to discuss all together is training with these new technologies. Now, looking in the energy, what do we know about the energy? It was fortunately enough at the beginning we saw it's just the interaction of shear and tear forces, and that is too simple. Everybody and the physicists told us, but nevertheless, after 30 years, we don't know exactly what is acting, and so few things we know. I think the shockwave energy is most responsible for the fragmentation. And on the other side, because stone treatment is an interaction between the benefits of fragmentation and the side effects. So we have to find lithotripters which have a major fragmentation power, but induce less traumatization. And so it looks very much that the energy flux density is a major factor inducing, as you see here, what we could show in experiments with pig kidneys, is a major factor of the traumatization of renal parenchyma. Now, and these goes now to the more clinical application, and I think Professor Della Rossetti showed these pictures about the AOA guidelines just recently at the Mannheim meeting. When you see at the guidelines what about ESWL, it looks, at least on paper, very promising. In nearly all stone, with the exception of the stones bigger than 2 centimeters, ESWL is kind of the first choice therapy. And we just want to show you again a slide which was just shown by our friend Hans-Göran Tiselius at the Mannheim meeting, which compared the 7-year output and outcome of ESWL treated and PNL treated calcium stones. And when you see beside over these times in regard to the need of retreatment, to the in regard of recurrent stones, both techniques seems over a long run very, very comparable. That we didn't expect it from the immediate and acute pictures. So I told you about indication. It's very important about stone localization. And if you look for the lower pole stones, there was the American lower pole group, which indicated that in principle each lower pole should be handled by percutaneous access. That is meanwhile proven to be not right, and you see a lot of papers which can prove that the lower pole stones can be treated nearly the same way like all other pole stones with ESWL. Now, huge discussion coming up from the HM3, from the problems to localize ureter stones with the HM3. The ureter was and is in some parts of the world still a kind of a contraindication for ESWL. That is not right, and we have this beautiful study on 1,000 consecutive patients from Hans-Göran Tiselius, which summarized which consistent use of SWL, a stone-free rate of more than 97% can be attained. And when you look in a very recent publication that even the urgent shockwave lithotripsy as first-line treatment for ureteral stones is very successful. These patients were, as soon as they are submitted in the hospital, no stents, nothing else, just pain medication and an immediate ESWL, and he come up with a very astonishing success rate. So the things is, that is one point which is not mentioned on the guidelines at all, and we should look in that. We tried to practice these in Munich since 5-6 years and found the same possible success, even higher success than waiting too long for the edema. Now, what about obesity? Obesity was one, in the beginning, one of the first reasons where they said, we have to do percutaneous access because ESWL cannot treat these kind of patients. Although this is proven, meanwhile, that it is not the right indication, if that is the only reason, because obese patients can be successfully treated with ESWL. Another point is, and that is this kind of a little tragedy, still children go in surgery for stones, and that is for sure the wrong access, maybe because it's mostly done, and these patients are mostly seen not by a urologist, they are seen by a pediatric surgeon. And I think if you look for these numbers, ESWL works as a first-line treatment for children, and I think the most of you will agree in that, and it's astonishing to see how easy the stone discharge is happening in children. And there's also just a recent paper published which show that there is no long-term side effects in children treated with ESWL. They found, after a mean follow-up of 5.2 years, no alteration because of the ESWL treatment. Now, for the procedure itself, the thing is that during expiration and inspiration, and that became more acute in Europe because we meanwhile do no anesthesia at all. In the US, still anesthesia is done, and so the movement of the patient might be more regulated. But if you see on these pictures the difference between inspiration and expiration in some patients, and consecutively, we didn't get the hit rate which we wanted to do. And I just show you on this table here how the hit rate of the ESWL decrease if the stone moves during treatment 1 centimeter or 2 centimeters. So you get out with a strong movement of the stone, you got only 1/3 out of the energy which you want to apply to the stone. And that brings up the pain management as a very important part, because if a patient has pain, he will move even more. But we found out with the new lithotripters, there is no need of anesthesia, but there is need of analgesia, and that what we, meanwhile, in Europe or in the most parts of the world, perform and perform quite successfully. In the US, there is still the main strategy to have full anesthesia for ESWL, but that is not needed. Together with the movement, there comes the problems with the new lithotripters in regard to the coupling. On one side, the coupling could be improved by the new devices where you have a versatile coupling of the therapy head, and especially for the stones and the distal ureter, you can move your therapy head up and treat much and recognize the stone much better. But with the coupling itself, if you see here, and that we found on many places, a very important part of the whole procedure. If you don't do a proper coupling, you lose a lot of energy. And again, if you have a 2 cubic centimeter air included in the coupling cushion, you lose approximately 50% of your energy. So if the patient moves and you don't do a proper coupling, you are back to an energy of approximately 30% what you have for your treatment available. What we learned is that the ultrasound gale should have a low viscosity, you should have a proper amount of gale, and you have to prepare, in some cases, the skin and remove the hairs of the patient on the coupling side. Now, to improve the coupling, I think there was a very new way which Boris et al. Published in the Journal of Urology just recently, and they control the coupling itself with a video camera, and that gives you very nice pictures, as you see here, where you can control if you have a proper coupling or not, and that should improve the energy transfer and your results significantly. Now, going to the rate of administration of the frequency, and there are meanwhile enough data available that you have a better disintegration effect with low administration rate and less shockwave pulses for fragmentation means automatically less tissue damage. And so what we also learned, and that's mostly due to the data of Jim Lingemann, that if you have use energy escalation strategy, your damage of the kidney and the renal parenchyma is significantly lower than when you start immediately with high energy shockwave impulses. We will hear a lot of meetings, of lectures about supportive therapy. I just want to show you from some data and from, for example, the work of Zhang, which showed the double better stone clearance in patients after ESWL with supportive therapy. And most agree, meanwhile, that the alpha blocker therapy as therapy, medical therapy after ESWL is a successful way to improve your results. Now, what in regard to minimizing renal trauma, let's do and try to bring these studies together, which has shown a pretreatment with low shockwave energy is very helpful. We use energy escalation strategy. The shockwave frequency should be around 60, not 120 like it is still in a lot of places used. We use delayed treatment, wait 1 week between one and the second treatment, and there's discussion about using kidney protection with nifedipine and antioxidants. For the last point, I just wanted to go in these which came up approximately 5-6 years ago, that ESWL should induce diabetes mellitus. There is meanwhile a clear no, and there are enough papers available which prove that that is not the case, and the same is to arterial hypertension. So there are no long-term side effects, and to make these more sure, even Dr. Grumbeck, which brought up the diabetes and hypertension study from a Mayo Clinic study, published meanwhile 2 papers which refuse the primary data, though it's don't worry about diabetes mellitus and hypertension after ESWL. So what we seems to have as conclusion is a larger focus seems to be more effective, less traumatizing. There should be power ramping used. Lower shockwave frequency are more effective and less traumatic. A good coupling is of utmost importance. BMI is not a predictive factor or contraindication. Pediatric ESWL is safe, also on long term. ESWL in ureter stones, even as emergency treatment, has been proven to be successful. Hypertonus and diabetes are no long-term side effects. What I think, and I mentioned in the beginning, we need training to go back to the old rules, which ESWL was performed to give these 90% success rate, which we did in Munich in the early 80s. And what about the future? Maybe even a little longer for ESWL. I mean, we saw it's part of the guidelines as a primary therapy for stones. And if you look for the characteristic of ESWL, it's non-invasive, anesthesia-free, outpatient procedure, easy to repeat. ESWL is a preference of the most patient, and what I learned, even of the most stone-forming urologists. Thank you very much.